Good evening, everyone, and welcome to Mahamana case discussion series. For today's session on carcinoma of unknown primary, we have Dr. Shivakumar Thiagarajan. He's a professor of head neck surgery at Tata Memorial Hospital, Mumbai. And we have specially invited him because he's also running a trial on management of carcinoma of unknown primary. So he'll be the best person to speak about the same. Shiva sir, you can please share your screen.
Okay, so
Yes,
I shall start.
Yeah.
Okay, so thanks for having me, Asim, for this session. So the talk is on management of cervical metastasis of unknown origin. So basically, my talk is going to be based on this ASCO guidelines or the recommendations that they have published in JCO in 2020. My talk is essentially going to be based on most of these recommendations. So just to introduce, metastasis of cervical metastasis of unknown origin, it's a rare cancer, and it accounts for 1 to 4% of all head and neck cancers. And what we need to understand is that basically it's a diagnosis of exclusion. So once we have ruled out a possible primary and done a workup and a thorough clinical examination is when we can come to this diagnosis. So you'll understand that as I towards the end of this talk. And majority of these cervical metastasis of unknown origin is of squamous cell carcinoma histopathology. So for the sake of convenience, I would just use there are various synonyms, MUO, CUPS, various other things. So I'll just, for the sake of convenience, refer to this as CUPS henceforth. So the definition of CUPS is that it's a metastatic disease in the lymph nodes of the neck without any evidence of primary tumor in the upper air digestive tract after appropriate investigations. So this includes clinical evaluation and thorough investigations. So this is the definition, and we should label a patient as metastasis of unknown origin, understanding this definition fully well. In the past, we used to have patients being labeled as CUP because of not being evaluated thoroughly in terms of clinical examination and in terms of thorough investigation. So improper clinical evaluation might give you a small primary with a big a nodal presentation might be misdiagnosed as a CUPS, wherein if you thoroughly examine you will pick up the primary. So that is not a case of CUPS. So we need to understand that very well. So a good history and physical examination, including Hopkins examination or an indirect laryngoscopy or a fiber optic laryngoscopy. Hopkins is probably mostly available in many of these centers. So I think we should be doing a good examination of the oral cavity, oropharynx, larynx, hypopharynx, and of course a diagnostic nasal endoscopy to examine the nasopharynx. Most common presentation of CUPS is in terms of a painless neck mass. That's what brings the patient to you, and without any possible symptoms, which would probably be pointing towards a possible primary. And most often, the stage at which they present it's in an N2A or an N2B, like multiple neck nodes, or about 3 to 6 centimeters within that range. And mostly they present with a level 2 nodal disease, and many a time, as you said, it can be more than one, and usually it is unilateral, but you do see bilateral neck nodes quite often. But the majority of the time, they would be unilateral. So we need to understand the painless cervical lymphadenopathy has a few differentials, which we need to keep in mind during our evaluation. It could be tuberculosis. Patients can have the neck nodes. You have to rule out fever, pulmonary symptoms, loss of weight and things like that. And lymphoma, again, the patients might have generalized lymphadenopathy, which also the patient with tuberculosis might have. So thorough clinical examination, history of tuberculosis in the family, all these things, needs to be kept in mind. So we need to keep lymphoma in mind as well, and the symptoms which the lymphoma patients have. So that also needs to be evaluated. And regional metastasis from head and neck subsites, especially cutaneous malignancies of the scalp, needs to be kept in mind, because sometimes it may not be evident to the patient, but then they may present with a neck node. So a thorough clinical examination is also a must. And neck node swelling in different levels, like starting from 1 to 4, might point towards a possible primary in certain head neck sites. Like, for example, when it is in the 1 to 3 lymph node, it could be the oral cavity, which is most common, or in the oropharynx and things like that. And also the consistency of the node. If it is cystic, we need to, now in the era of HPV malignancies, it could be either HPV positive primary somewhere in the upper digestive tract, or it could be a papillary thyroid carcinoma. So we need to keep all of these things in mind. Now let's look at the, how do we investigate? Once you have done a clinical examination and you don't see a primary in your clinical examination with whatever you have done with an Hopkins and whatever has been mentioned so far, we need to know how we are going to proceed with the investigation. Now, first, we would probably be doing an FNAC to understand what is the histopathology. And FNAC is an efficient, minimally invasive, and available all over the place, and it's cost effective, and it has a good sensitivity and specificity, except when it is a cystic node. And if FNA is negative, then it should be repeated, or preferably image guided, or at certain instances you would probably want to do a core biopsy as well. Nowadays, at least in the trial, we do a core biopsy because we need to, as per the ASCO guidelines, to have a core biopsy. We will talk about it as we go ahead. Open or excision biopsy is definitely not recommended. Tumor spillage and disruption of facial plane is a major concern. It can be considered only if you're suspecting lymphoma, and true cut biopsy is a good alternative on which IHC studies can be done. Once it's a lymphoma, if your clinicians or medical oncology colleagues ask for more sample, then you can be more sure and do an open biopsy to give a full node for them to do other studies to treat lymphoma, but not otherwise. Open biopsy should definitely not be done. The first investigation should be an FNAC or a core biopsy, if at all. Now, as per the ASCO definition guidelines as well, P16 and Iberish from the node is very much essential. To understand as to whether the patient is having HPV positive or negative disease, or a possible disease originating from the oropharynx or nasopharynx, one of the two. So only if you do a P16 from the neck node, which is from an FNA, it's going to be highly challenging and difficult to do. So if you have a core biopsy, you can do a P16 from the core biopsy, and if it is positive, you don't have to do an Iberish. Only if P16 is negative, you would have to do Iberish to rule out a possible primary from which is originating from the nasopharynx, or Epstein-Barr, a virus-based kind of a disease. So on the designation, T0 is reserved only for virally mediated metastatic carcinoma. That is when these are positive. Otherwise, it's it is designated as TX. All HPV negative and EBV negative metastatic carcinoma should be staged as per the end stage, which is there in the AJCC classification. And IHC might be recommended if necessary, based on what is seen under the microscope, to rule out the possible histopathology type as well. But now we know that the majority of the times it's a squamous cell carcinoma or next followed by an adenocarcinoma. Then you don't have a primary elsewhere. And once you've done an FNAC, and then if it is a squamous cell carcinoma, which is the most common, let's think of it that way and go ahead. And the imaging of choice, the first recommended imaging is contrast enhanced CT scan, which is the first investigation that is recommended by the ASCO guidelines as well, and which is also available in most of the places. And it is helpful in identifying the primary in up to 23% of the patients, and helps get a positive yield when it is an image-guided biopsy in close to 60% of the patient. So a biopsy should be considered from the possible mucosal site of the upper aerosolized tract after imaging, not before that. Before imaging, probably you'll only do an FNAC or a core biopsy from the neck node, and not a biopsy from any suspicious upper aerosolized tract lesion. And the CT scan also helps us understand, if there's any possible primary in the upper aerosolized tract, and also the extent and number of the nodal disease, if there's any extranodal extension, presence of retropharyngeal nodes, whether it's unilateral, bilateral, and also if you're considering surgery at any point, whether the node is operable or not. So it helps in all these ways. Now, most of us, probably many of us, not most of us, many of us would probably, resolve to a PET scan. And there are these three meta-analyses which have mentioned the utility of this investigation. So as per the recommendation as well, if the primary is not evident on clinical examination and CECT is when PET scan is done, but then you wouldn't be wrong in asking for a PET scan upfront, but then we should be judicious in what we are asking for based on the availability of these particular investigations. So the primary detection rate definitely is, anywhere between 24 to 37% based on these three meta-analyses with a good sensitivity and a reasonable specificity as well. And this is another study from Tata Memorial Hospital, which tells us the good sensitivity of detecting the possible primary or even multiple nodes or distant metastasis. And there is a good sensitivity for the PET scan compared to the conventional modality. And it has changed influenced the overall treatment decision in close to 39% of the patients. And it has helped detect multiple nodes or presence of distant metastasis. So most of the times here in our practice, we would do a PET scan, but you wouldn't be wrong if you have a CCT, head, neck, and thorax. That would be the basic minimum. Probably in this case, you will also have to include the abdomen and pelvis. So a CCT of the head, neck, thorax, abdomen, pelvis should be good enough if you don't have a PET scan. The next is, once you're done an FNAC or a core biopsy, you've done an imaging, and then you do an examination under anesthesia and possible directed biopsies, or if you find anything suspicious on your imaging. And it has a PET scan has a relatively high false positive rates, and also you have a negative predictive value, which is reasonable, but false positive rates, you need to do the PET scan examination, the anesthesia, to take a biopsy and confirm the possible primary. So it has to be confirmed if you have anything suspicious on a PET scan or a CT imaging. And it should be, so that is why, because if you do a biopsy before the imaging, you may have false positive findings. So that's why the biopsy is better done after your imaging. And also it helps us to have a more image directed biopsy, which will increase your yield. So once that is done, your examination anesthesia should be a very methodical, systematic process wherein you will do a nasal endoscopy to inspect and examine the nasal cavity, nasopharynx, and then you have to examine the oral cavity, oropharynx, larynx, epipharynx thoroughly. And also palpating the base of tongue is very essential, and the tonsil region, because sometimes you might have some submucosally indurated lesion in this area. And if there's anything suspicious, and based on your imaging and your examination anesthesia, is when you would take a biopsy of those particular regions, those particular sites. The other concept that is evolving to a certain extent is the use of narrowband imaging to help guide your biopsy in any suspicious region in the upper aerodigestive tract. So random biopsies of non-suspicious area, the blind biopsies, the so-called blind biopsies, definitely it is condemned. It's not recommended at all. I'll come to that a bit later. Now, in this study, which was published in the early 2000s, a PET scan followed by endoscopy directed biopsy with or without tonsillectomy, he had a better yield of the primary and a lesser incidence of false negative rate. So again, emphasizing the fact that a biopsy should be image guided, be it PET scan or a CCT, which for a better yield. Coming back to the NBI guided biopsy, there is a lot of literature that is available, mostly retrospective series, and this meta-analysis of these retrospective series says that it improves the primary detection rate by up to 35%. But if you look at this forest plot, it is like on either side of the line of unity, and the confidence interval is on both sides. Though it claims to be 35%, we need to understand these are all from retrospective series that you understand by the I-square there, 70.37%. So there probably might be a role, but it's still not well established. So coming back to the blind biopsies, this is one of the papers published earlier on, wherein 156 patients of cups, blind biopsies were taken at nasopharynx, the fossa of Rosenmuller, piriform fossa region, tonsillectomy done in ipsilateral bilateral area, and basal biopsy. So the yield of positive lesions from these blind biopsies was very less. So in conclusion, it is definitely, even in the ASCO guidelines, it is recommended not to do blind biopsies, especially in the era of such good imaging modalities with good sensitivity and specificity that are available. We should be doing more of image guided biopsy rather than random biopsies, and certainly there's no role for that. Now, once you've done all these investigation biopsies in a negative, the next thing is, the guidelines recommend that there's the role of tonsillectomies and mucosectomies. Now, let's look at that. So there are studies. These recommendations are given based on certain studies over the years, wherein ipsilateral tonsillectomy has provided a good yield of 18 to 44%. And it's better than doing a deep tonsillar biopsy because the yields are better, and you can take multiple sections and whatever that tiny primary is detected. And however, these numbers are coming from small studies and they're less convincing, and especially for bilateral tonsillectomy. And of course, there are no randomized trials comparing the survival outcomes between patients who have and have not undergone ipsilateral tonsillectomy. So if, for example, if we don't do tonsillectomy and treat the patient like MUO, is the survival any better or worse? We really don't have an answer to that. It's just said that you can find out the primary, and so probably that helps you direct your treatment better, especially if it is a non-surgical treatment. So that would probably minimize your toxicity, whether it's surgical or non-surgical treatment. But then there is no evidence to say that one is better than the other in terms of doing tonsillectomy or not doing tonsillectomy. Now, most of these procedures are done using laser, or now with the advent of Da Vinci, mucosectomies are done using robotic surgeries. So there are 21 studies, these systematic reviews, wherein when you looked at patients who underwent TOS and TLM, the yield of primary was up to 78%. But we need to understand that all of these were predominantly in HPV positive patients and in HPV positive population. Now, if you look at whether there is a yield of this mucosectomy and tonsillectomy in HPV negative patients, it's definitely a no, because in this study, when the sample size is small of 23 and 47 patients, the yield of primary in an HPV negative patient is very less, or zero in the study that which is in the lowest section of the slide. However, the use of intraoperative frozen section has, it's been claimed to increase the primary detection rate in up to 89%. It seems to be, a useful and safe adjunct in diagnostic and therapeutic pathway in case of CUPS in an era of increasing incidence of HPV positive oropharyngeal malignancy. That is the mucosectomies and tonsillectomies with the use of frozen section. But however, the cost, affordability, and availability is questionable, because the use of the literature on mucosectomy has increased after laser, but much more after the advent of tonsillectomy. So after the advent of Da Vinci robots. So of course, it's now the availability is getting better, but affordability remains a concern even today. And though all these studies, mention that the effectiveness of transoral surgical techniques in identifying primary is better, the quality of these studies and the heterogeneity of the data limits us from reaching to any conclusive findings. As mentioned, by doing or not doing these procedures, it's not having any. There's no a study which shows any survival advantage or a detriment to survival by any of these procedures. So even if you don't do it, and you still treat the patient, the survival is not going to be any different. And we here in our institute definitely are not doing any of these procedures. We are, of course, doing a thorough clinical examination, FNAC, imaging, examination, anesthesia, and then we label the patient as metastasis, as CUPS. And this was one Indian study, a recent study. Again, the incidence of detecting a primary is almost 0% in P16 negative patient. Again, reiterating the fact that the yield is better in HPV positive patients, but not at all in HPV negative patients, which is our Indian scenario. We have HPV negative patients, which is the in the majority that we see in our practice. So definitely, this is from Western literature, which is driving these guidelines. But we need to understand the Indian scenario and tailor our treatment. Now, coming back, this is a flow chart of how you would go about doing an investigation. This is there in your, in the ASCO guidelines. You can just have a look at that. But then this concept of, this thing of, tonsillectomy and mucosectomy is questionable. We don't do it in practice. Of course, it is recommended. There is some evidence, but there is no evidence, to say that by doing or not doing, you're going to have any improvement or detriment in survival. So we need to understand that. Now, once we have done all of this, investigated, now it's a cups. How do we treat the patient? Now, for head and neck cups, we have both, surgery, which is I'm talking about neck dissection. I'm not talking about tonsillectomy or mucosectomy. We have dealt with it already. Now, once the treatment here is in terms of, neck dissection, followed by adjuvant treatment, in form of adjuvant radiotherapy or chemoradiotherapy, or definitive radiotherapy or chemoradiotherapy. When do we do what? So for unilateral small volume neck disease or small volume bilateral neck disease with no clinical evidence of extranodal extension and small large volume neck disease with gross extranodal extension, both of these treatments can be offered. There is evidence for both of these treatments to be effective. All these are from retrospective series, and there are quite a few systematic reviews of these retrospective series. I don't recollect any prospective series, at least as of now, and they do show almost equal effectiveness in terms of treatment outcomes in terms of survival, be it overall survival or disease specific survival. So, but then yes, there are certain systematic reviews which show surgery is better. There are quite a couple of them, and then there might be some which says non-surgical treatment is better. But there's no clear winner here. There is an clear equipoise in this, and there is evidence to support either of the treatment. And probably the treatment is mostly driven by your institute protocol. It would probably depend on that as to what is being offered, because both can be offered as of today and are considered as standard of care. Now, this is one systematic review. Of course, it's a quite older one, but most of it is mentioning the same. Now, is there any randomized control trial in cervical metastasis in cups? Yes, there is one randomized trial which was attempted by the EORTC in head and neck cups. The sample size was ambitious at 600. They were looking at selective irradiation of ipsilateral neck once daily to pan-mucosal irradiation. So this is another concept, I think, which Sarbani madam will be alluding to during the discussions subsequently, which actually, if you have to do pan-mucosal irradiation coming from nasopharynx down to the hypopharynx, that increases the toxicity. So there is a lot of controversies and gray zones there, because it increases the toxicity, and a lot of debates as well whether you should do it. Some radiation oncologists do it electively, some don't. So that is again, so this randomized control trial tried to answer that question with DFS as the primary endpoint, but had to be terminated due to poor accrual. So the optimal regional therapy for CUPS is somewhat controversial given the absence of randomized data on this question. Now, this is the flow chart that is available in the same guidelines. You can just refer to that. If it is definitive surgery based on levels of node, which should be routinely dissected, is level 2 to 4. You can do an SND as well in N1 or N2A kind of N1 mostly kind of a disease, or you wouldn't be wrong in doing an MND as such. There's no clear-cut demarcation. So N1, and if you look at the guidelines, even the UK guidelines, N1 and N2A disease less than 3 centimeters, a smallish N2A, you can still do 2, 3, and 4, but not for more than that, or multiple neck nodes or bilateral neck nodes. It will be an MND, and followed by adjuvant treatment, which will be radiotherapy with or without chemotherapy in the presence of extranodal extension. And the doses are given here. I think Sarbani madam will again allude to you about that. And patients can also be kept under observation after a neck dissection if it's a single pathological positive node without an E&E after a good nodal yield. That is, a nodal yield as per the ASCO recommendation is at least 18 nodes or above. And so if there is a single node, N1 disease, no extranodal extension after a good neck dissection, you can probably keep the patient under observation. That will very few patients, but then if you have that situation, you can do that. And radiotherapy doses of up to 70 grays have been recommended. Of course, there are the other, how much of radiotherapy to given to the other parts of the neck is also mentioned there. And of course, the aspect of mucosal irradiation is controversial. Again, we will discuss that as we take the cases from here on. And this is in general about the the broad outlay of how you would treat the cups, in terms of surgical or non-surgical treatment. So clearly there is an equipoise, and currently we are running here at the Tata Memorial Hospital randomized control trial. Again, a sort of ambitious trial, but slightly lesser ambitious than of course, it's a adequately sample size, a multicentric trial funded by the National Cancer Grid. We are looking at upfront neck dissection with adjuvant or chemoradiotherapy as well as salvage neck dissection with neck node, SNDosis, MND, and mucosal irradiation as stratification factors. We have a few patients enrolled as of today. Hopefully, we hope to answer this question one day or the other. Thank you. I can take questions, or we can probably discuss all the questions that is there in the case discussion. Thank you for your attention.
Thank you so much, sir, for the excellent talk. I have one question for you. So whenever we are comparing, even in a randomized setting, we are trying to compare radiotherapy or surgery followed by adjuvant therapy. So is there any selection criteria? Like when we operate, we have a selection criteria. Similarly, when we are going to radiate, is there any selection criteria or bioselection which is going to tell us that in this patient, this is actually going to work?
So we don't have that, but for surgery, I can definitely say that we would be considering, at least in this trial, is for those patients who are resectable. The nodes that are resectable can be considered even if you have to do a bilateral neck dissection. If it is unresectable, definitely those are not surgical candidates. You probably need to consider non-surgical treatment option. If you're asking the question of role of neoadjuvant chemotherapy in this to bioselect, there is absolutely no data on that in case of metastasis of unknown origin. That could be one of the strategies that you could consider in sort of gross extranodal extension, or those which are sort of borderline resectable or unresectable nodal disease. In such a situation, probably that criteria could be used, but we really don't have data on how to bioselect the patient as far as patients with cups are concerned.
Okay, so maybe probably we'll have certain criteria in future where we'll be able to identify like which patients actually will be treated by radiotherapy rather than submitting all patients to either surgery or radiotherapy and then say that this is better, rather than selecting what is better for the patient.
Caleb is asking a question as to any size cutoff. I mean, as long as the node is resectable, we can consider for surgery, I guess. I mean, it depends. If it is resectable, if it is a fungating node, I think we can discuss all these points if we, as and when we discuss the case. If the node is resectable, we can consider between surgery and radiotherapy. So that is exactly the debatable aspect. If it is unresectable, there's no question. You're not going to attempt surgery. In the resectable nodes, be it unilateral or bilateral, you would want to consider surgery if it is possible. So here there is an equipoise, and that's what we are trying to answer.
So I think we'll start with the case presentation. And we would want that during the case presentation, there will be definitely a lot of controversies in management. But during the case presentation, we would want that all the residents and everybody is clear that what exactly is the management of the cup, and they're able to arrive to that conclusion by the end of making the decision for the treatment. And for the case presentation, I would like to invite Dr. Latika. She is a resident at Tata Memorial Hospital, Mumbai. And as examiners, I would like to invite Dr. Shivakumar Thiagarajan, Professor of Head Neck Surgery at Tata Memorial Hospital. Dr. Sarbani Ghosh Laskar, she's a Professor of Radiation Oncology at Tata Memorial Hospital, Mumbai. And Dr. Sambit Swarup Nanda, he's Assistant Professor in Radiation Oncology at Mahamana Pandit Madan Mohan Malviya Cancer Center, Varanasi.
Asim, I'll just log out and log back in again in a minute.
Sure, sir, sure. Latika, you can please share your screen.
Yes, sir. Good evening, everyone. Mine is a 52-year-old female from Ghosh, from Uttar Pradesh, housewife by occupation. Complaint of
Latika, can you just make it to the slide presentation? Slideshow.
My patient is
You can just press F5 on your computer. You can just press F5 on your computer.
My patient is a 52-year-old female from presented with a complaint of the swelling on the right side of the neck since 2 months. History of present illness. Patient was apparently 2 months swelling in the right side of neck, which was insidious in onset, small in size like a lamp initially, and then rapidly progressed to the size of this present size. That was not associated with any pain, no history of any discharge from swelling, no complaint of any ulcer in the oral cavity, no complaint of no complaint of foreign body sensation in the throat, no complaint of throat clearing, no complaint.
I missed one name. Another examiner is Dr. Elizabeth Matthew Iype. She's a professor of head neck surgery from RCC Trivandrum. Sorry, madam, I missed your name.
Yes, good evening.
Yeah.
Hi, Elizabeth.
Hello, Sarbani.
Housewife by occupation, complaint of swelling in the right side of the neck since 2 months. History of present illness, patient was apparently asymptomatic 2 months back when she noticed a swelling in the right side of the neck, which was insidious in onset, small in size, and rapidly progressed to the present size. Not associated with any pain, no history of start from the swelling, complaint of any ulcer in the oral cavity, no complaint of difficulty in breathing and swelling, no complaint of foreign body sensation in the throat, no complaint of repeated throat clearing and throat pain, no complaint of blood sputum, no complaint of any nasal blockage and nasal discharge, no complaint of cough, no complaint of pain in the ears, and no complaint of significant weight loss. And no history of fever, no history of abdominal symptom, no history of abdominal symptom, no history of cough, evening rise of temperature and night sweat, no history of contact with the patient with tuberculosis. Past history, there was no history of a similar complaint in the past. The patient has a history of hypertension since 1 year on medications. Patient was hypothyroid since 2 years and on tablet erythroxine 100 mcg. And there was no history of surgery in the past and no history of radiation exposure in the personal history. The patient has a normal bowel and bladder habit, normal sleep and appetite. Patient taking mixed diet, married, having 2 children. Menstrual history stopped since 3 years. Family history, there was no significant family history of the similar kind of illness or cancer in the family. Patient belongs to a lower middle class. Summary of my history now: 52-year-old female from Gorakhpur, a housewife with no history of addiction, presented with a complaint of swelling in the right side of the neck since 2 months, rapidly increasing in the size with a history of hypertension and hypothyroidism. Examination. General condition: fair and bright. Patient comfortable at rest. Average build and nourished. BP 120/70. Recorded in the right arm in sitting position. Pulse 90 per minute. Regular in rhythm with volume. Respiratory rate 18 per minute. Regular. No pallor, icterus, cyanosis, clubbing, and generalized lymphadenopathy, medulla. On inspection, examination of neck. Approximately 4 into 3 centimeter size, single rounded, well delineated swelling present in the right side of the neck, corresponding to level 2. Seen over the swelling looks normal. No pulsation seen over the swelling. No discharge from the swelling zone. No other swelling in the axillary neck or the contralateral neck. On palpation, I confirm my inspectory findings. 4 into 4, single swelling in the right level 2 area, extending below the level of angle of mandible till the hyoid. Medially not reaching the midline, laterally below the sternocleidomastoid muscle. Skin of the swelling is pinchable. The swelling is firm in consistency and mobile. Temperature of the swelling is normal. Surface of the swelling is smooth. No blue, palpable of the swelling. No other swelling on the inside of the neck, contralateral neck, and the midline of the neck passage. On examination of the oral cavity, mouth opening adequate. No restriction in the proceeding of tongue. Poor dental hygiene, lip, gums are empty, floor of mouth appears normal. On oropharynx examination, bilateral tonsil, femur, fossa, soft palate, rotated penthouse appears normal. Examination of the scalp, skin over the head, neck, no churn and yet normal. Pigmentation and swelling. Hawking examination, base of tongue, valvular epiglottis normal. Bilateral erythema is normal. Bilateral pulse core normal, bilateral vocal cord normal and mobile. Skin adequate, bilateral pyriform sinus. on direct nasal endoscopy by little nasal cavity surgery nasal padding seems examination also broadly normal. Provisional diagnosis: suspicious metastatic right level 2 cervical mobile node without any skin involvement. No clinical evidence of extranodal extension with occurred primary in the 52-year-old female with no history of addiction. Clinically, the XN2A MD. So let's proceed with walk-up.
So Latika, one question from my end. Did you palpate the base of tongue or the
Sir, I
tonsil
palpate
area?
Yes, sir. I palpate the bilateral base of tongue, posterior tongue, base of tongue, anterior pillar, and the tonsil. Not fully, but whatever patient allows me, I palpate.
Right. Okay.
Latika, can you go back to your examination finding of the neck? Okay. Yeah, you were telling everything about the neck swelling, but have you examined the thyroid, the carotid pulsation? Have you mentioned that? I didn't hear it in
Yes,
your
ma'am,
palpation.
No, we were palpable over the swelling of pulsation palpability.
No, you haven't mentioned about the thyroid gland. You have to mention about whether there is thyromegaly, whether the thyroid palpable or not, and about the carotid pulsations bilaterally, about the laryngeal framework. All these things have to be mentioned in your palpation. And also the status of your cranial nerve examination. That also you didn't mention. For every head and neck examination is incomplete without a cranial nerve examination, especially the lower cranial nerves also. Okay.
And Latika, what is your differential diagnosis for this neck swelling? If you can just put that clinical picture of that lady and just tell us what are your differential diagnoses.
First is the differential diagnosis that there is a unknown primary with the suspicious neck node, and the second may be a nodal met from the thyroid, and it can be considered as a.
This is you have to tell about the differential diagnosis based on your clinical examination. You just have to think broad now.
Sir, it can be a nodal swelling due to the infectious disease like tuberculosis, granulomatous disease, bronchogenic brachial cyst, and lymph node from the thyroid.
Right. You have not mentioned paraganglioma or carotid body tumor. Any reason?
No, it can be paraganglioma.
What is the duration of symptoms that he's been having?
Sir, he is giving the history of 2 months.
That is right. So you can say, that will be a differential just based on its location. But when you're saying, you can say why it is least likely to be that because of the duration of swelling. It was not there prior to that, right? Because if it is a paraganglioma, it's going to be a slow-growing swelling, increasing in size slowly.
I'd just like to ask you something about the history that you presented. You gave a lot of negative, important negative history, but I hope you understand the significance of all the negative history that you presented. So one of the points that you did present as a negative history was no history of exposure to radiation. Now, can you tell me, when you've seen this patient as a whole, what does the implication of negative history of radiation exposure imply in this particular case?
Ma'am, if we are suspecting in the primary in the skin, which gave the movement. So maybe the patient is previously irritated because of some skin primary, which is not seen as a any
But why are you thinking of a skin primary in this lady? Is there anything to suggest a skin primary? See, what I'm trying to tell you is essentially when you give all this negative history, you have to know why you are taking this history and what is the implication of that negative history. Now, if I ask you, why did you ask history of weight loss, night sweats, fever, you will tell me. What will you tell me? No, why did you take the history of fever, weight loss, and night sweats? What did you think?
I want to rule out the history of tuberculosis or this nodal swelling.
Yeah. So what do you think it could be? A lymphoma, right? So that's why you ask those questions. So similarly, when you ask about radiation exposure, what it is that you're thinking of? I think Dr. Elizabeth asked you a relevant question is, did you examine the thyroid? And if you say skin cancer, especially for the location of that lymph node, and did you have any indication to say that this patient could probably have a skin cancer? So what I'm just trying to tell all of you is that when you take negative history or you talk about negative history, you should also know why you're asking that particular question. Just don't rattle off a whole list of things. You have to know why you're asking. You're right. You ask for history of tuberculosis. You ask for history of night sweats, temperature, diurnal variation of body temperature. You can say tuberculosis. You can say lymphoma, night sweats, weight loss, again lymphoma, because this is, you think, an unknown primary with a neck node metastasis. So you should know why you are asking a particular question or why you are saying it, because negative history is important. But what it is, you have to be able to justify. Okay, na? Thank you.
Dr. Latika, can you explain why you have taken the history of no cough while eating?
Sir, I'm reading out the history of any to without any even in the area.
Sorry, I couldn't get you.
Sir, I'm reading out the history of aspiration here. And the future cases which may result in the aspiration in the larynx.
Sorry, excuse me. Latika, is it possible for you to move somewhere where you have a steady network? Because somehow, your voice is coming out all muffled and can't hear you very clearly. I don't know whether it's only with me, and I'm sorry, I can't hear you too well.
Agree, ma'am. I think her network is a problem. I think you can move down to the other room. As I said, 202 is empty. You can just be there. So the signal might be better.
Yes.
So in the interest of time, let's continue, I think, because I think this is going to be a perpetual problem because of the network issues. Yeah, please continue. Yeah. Dr. Sambit asked you a question, so please go ahead and repeat your answer.
Yes, Dr. Latika.
Latika, can you hear us? Hi, Latika, can you hear us?
I'm audible.
Oh God, there are two.
No, clear, but even muffled now, but still better.
Yes.
Yes,
But
ma'am.
yeah, that's better. Switch off
Yes.
one of your mics, huh? Yeah.
Yes, ma'am. There is no complaint of cup while eating. So I'm ruling out here the history of aspiration.
Based on your history, are you expecting any aspiration
No,
till
sir.
this point?
No, sir. No, sir.
Okay, so was it essential to take that negative history? Because when you say something and you cannot corroborate it with the history that is present till that time, it is going to be difficult for you to explain. Just like ma'am said that you are suspecting that with radiation exposure, you are suspecting skin cancer. But in your case, there is no skin lesion or not even the node is involving the skin. So there is no point in raising a point which will lead to more questions rather than answers.
Yes.
Also, in the personal history, even though HPV is very rare, have you asked for the high-risk personal history?
Yes, ma'am.
Yeah, have you mentioned?
There is no history of any addiction smoking, and there is no history of any high risk feature like multiple partners, and there is no history of patient is actually not a young male or it's a middle aged female.
And what is
So
the
Latika,
yeah.
sorry,
So
Latika, it is
yeah.
not multiple sexual partners. Huh? You have to be clear, it is altered sexual behavior. And even in addiction history, you will not ask only about tobacco and your usual pan, gutka and all that, but about other things also, because the use of an HPV positive patient, what is the substance abuse that you typically get? Though tobacco is what has been quantified, what is the typical substance abuse, Latika? So yeah, tell. Yeah, marijuana. So that is something, because here you will get things like charas, ganja and all that. So these are things that you have to know about the Indian context also. Yeah. Sorry, Elizabeth, you were asking something.
Nothing. This was the only question I wanted to ask. So, Latika, your palpatory finding about the neck node, can you just repeat it again? The size and the consistency.
Yes. There is I confirmed my inspectory findings on palpation. 4 into 4 centimeters single swelling in the right level 2 area, cervical area, extending just below the level of the angle of the mandible till the hyoid, medially not reaching till midline, laterally below the sternocleidomastoid muscle. Skin over the swelling pinchable. Swelling is firm in consistency and mobile.
For this level 2 lymph node, what all probable primary sites you expect in head and neck?
And it can be from the
can you repeat the answer? It was not audible.
Ma'am, it can be from the oropharynx, floor of mouth, tongue, and nasopharynx.
Only that much?
Why? You are trying to rule out some aspiration and all that.
And it can be from the supraglottis. And if we are suspecting any thyroid primary, then also we can get the swelling in the level 2 area.
But Latika, why are you so particular that it can be only in the supraglottis and not anywhere else in the larynx, hypopharynx?
Sir, mostly the hypopharyngeal swellings presented in the level 3 and 4.
No, but then you cannot be so. So what is the other way of saying it? Because of the symptoms, she doesn't have any history of difficulty in swallowing or anything of that sort. But it still can be from hypopharynx. You're right. It might be more in level 3 or 4, but it doesn't have to be that way always.
Okay, sir.
So this is level 2A. Suppose you found out a node in the level 2B area only, or in the 5A area. So what will be the other probable sites in head and neck for the primary? A little bit posterior, like 2B or 5A.
Sorry, ma'am. Can you please repeat, ma'am, question?
Yeah, a neck node instead of in a 2A area, whether if it is in a 2B or in a 5A. What could be the sites, most probable site of primary?
Ma'am, it can be from the nasopharynx,
Yes.
from the hypopharynx.
No, hypopharynx may not be. You said it's most probably in 2, 3, 4 area. So I was asking about 5 or 2B. So most probably it could be from nasopharynx or nasopharynx, oropharynx, most probably this will go to 2A. So 2B and other posterior triangle lymph nodes, most probably from nasopharynx or from the scalp lesions, or even from the parotid, you can get some level 5 nodes. So other than that, larynx, hypopharynx, thyroid and all, the first echelon nodes will be in 2, 3, 4 area. Suppose if it was in the level 4, what extra sites you will concentrate on looking for your primary?
Ma'am, will rule out any intraclavicular primary sites, like from the abdomen, lungs, and breast.
So that is other than head and neck. In head and neck area, it will be
Yes.
thyroid, larynx, other midline structures, all can have to have lymph
Yes,
nodes
yes.
in level 4. So apart from this, you should give specific concentration or attention to your infraclavicular primary sites.
Yes, ma'am.
Yeah. So what is your staging?
Till now, ma'am, after examination, my staging will be TX, N2A, MX.
So why do you say this is a malignant lymph node? What are your points in favor of a malignant lymph node?
Ma'am, patient giving the short history of swelling, which started from a small swelling and reached to the site of the size of the present swelling.
Mm-hmm. Only the short history is point towards malignancy.
Yes, ma'am.
Clinically, how will you quantify a malignant lymph node? What are the clinical features of a malignant lymph node?
Ma'am, if there is any extranodal extension, or any
So you will come to a provisional diagnosis after a careful history taking and your clinical examination. Your history is short history, but your clinical examination should point towards your malignancy, the suspicious malignant lymph node. So you have to tell all the features of a suspicious malignant lymph node in your clinical examination. So one you said extra nodal disease. Other?
Ma'am, rapid increase in size.
Yeah.
Yes, sir.
Dr. Latika, you just said about extranodal extension. What are the features that will direct towards the fact that there is extranodal extension in clinical examination?
Fix the skin to the swelling. Fixity of the skin to the swelling and restricted mobility of the swelling.
So that will be fixity to where? One is skin, other one is?
Other with on the prevertebral fascia or the muscles, and with the sternocleidomastoid and the corresponding vessels.
So you said the size of the lesion, that is the neck node, is almost 4 into 4 centimeter. So
Yes, sir.
what is the chance of extranodal extension when the size increases from 1 into 1 to say 3 into 3 or 4 into 4, as in your case?
Latika, did you get his question? Did you understand the question, Latika?
No, ma'am, not exactly.
Or
So supposing your node is 1 into 1 centimeter in size, what are the chances that there may be extranodal extension versus if you have a node that is say 3 into 3 centimeter in size? Which one has a higher likelihood of having ENE?
Ma'am, it in the higher node with the
larger size.
Yes.
Yeah. Okay. So then in that, how much by proportion, what is the increase? Can you say that? Or that for that matter, there are others also on the other trainees also in the group. Can somebody answer this question? Because it's very important.
The others can probably put it in the chat box, I guess.
So roughly it is around 70%. So or beyond that, when the size increases beyond 3 into 3 centimeter. So can anyone from the group say that what is its implication for doing surgery versus deciding that whether to go ahead with definitive CTRT in such a scenario? Now the question remains that how does extranodal extension take part in making the decision going forward?
Latika, are you there?
Yes, sir.
Yeah, please answer the question. I think he's asking what are the implication of presence of extranodal extension? That's the question.
Sir, if there is an extranodal extension, so that node will become N3. It will be a stage 4B disease. So in that case, patient, if it's unknown primary with cervical, yes.
So presence of
Hello.
Yeah. So will it increase the chance of
how would you
resectability?
subclassify?
Sorry, sir, I didn't get it.
I think, Latika, you have to first move to a place where there's connectivity, and then you'll have to listen to the question. So the question is, what is the implication of presence of extranodal extension in terms of treatment? Yeah, go ahead.
Sir, it will upstage the disease. In terms of treatment, it will be treated as a advanced disease, and double modality treatment should be given to these patients.
So that is not a right way to say, not double modality. It has to be you have to mention it as multimodality. You can have a tri-modality.
Yeah. So sorry if I could intervene here. There is somebody on the chat who's asking this question again and again. Why do you think this is a cervical nodal metastasis? How have you labeled it as a metastasis? Am I correct? Is that the question you're asking, Dr. Muka? Because
yeah,
he's
I think so, ma'am.
Yeah. So
yeah,
how
definitely
do you
that has to be clarified because Shiva was asking about differential diagnosis. So how did you come to a conclusion that it is a malignant lymph node which is of unknown primary? Latika, you have
excuse
to
me
tell
for
all about
intervening. Can you hear me, Dr. Munka here?
Yes.
Yeah, we can hear you. Please go ahead.
Yeah, basically, before putting it as a secondary, we must rule out, like you said, about the carotid body tumor, others, because there also skin is free. How can we level it as a metastasis in the first go?
You're
because
absolutely right.
Unknown, yeah.
You're absolutely right. So that is where I think that we had asked this question as to what are the differential diagnosis. I think that is the the drawback of knowing the diagnosis upfront. I think they're unable to give a differential other than that. So that is why it has been labeled that way. But we have discussed that. We shall discuss it further.
You are supposed to do it from the basics that you don't know you have to reach to a diagnosis. Before putting into the diagnosis back of your mind, you must reach it.
You're right.
You have to rule out tuberculosis by doing certain investigations that will come probably next. And then the benign masses, then there can be some other. Tuberculosis is very common in our country. And that has to be ruled out because many cases, long-standing lymph nodes, quite enlarged, and with ATT, we could not prove that it is tuberculosis. Didn't find any other reason, gave a therapeutical trial for 1 month and it subsides. So that's why the question is before labeling is the unknown secondary, unknown primary, and it is a secondary, you must be very sure. Why do you call it as a secondary?
What point well taken. Yeah, point well taken, sir. I think we can discuss that. We can discuss that. We had discussed that briefly, but yeah, we'll go into it, do a bit of deep diving here. So, Latika, as what is mentioned, let's initially we had dwelled on that. So as to what are the differential diagnosis for this level 2 swelling? I mean, I'd asked you that question. So what is being said essentially, and even that is very important in your exam, is that you need to say A, B, C, or whatever that is the possible differential diagnosis. So what are the points for and against that particular differential diagnosis based on your clinical history and examination, and then you would do appropriate investigation to further narrow down on your diagnosis. You understand? That's the point being said here.
Yeah, very true. That is exactly what I meant.
Yeah. So you can you just once again, just to complete it so that we can move towards investigation and treatment, quickly tell what are the differential diagnoses in your mind for this level 2 swelling, and
Yes, sir.
1 point for or against it. Go ahead.
Yes, sir. Sir, it can be infectious tuberculosis node. So patient is not giving any history of the fever, any contact with the tuberculosis patient, no history of any cough and evening rise of temperature. So that will rule out my history of tuberculosis. And another is it may be from the swelling of the nodal mat from the thyroid. On a central neck examination, there was no significant swelling palpable. So that will rule out the suspicious primary from the suspicious primary in the thyroid. And
no, that again does not rule out. Again, Latika,
No,
you just have to
there
rule out.
There are specific features for differential diagnosis of each one.
Yeah.
So
Yes.
for a tuberculous lymph node, for a metastatic malignant lymph node, for a carotid body tumor, all these are different clinically. You don't have to repeat all your the history again and again. The history is understood. Everything is negative history. But the clinically, how will you differentiate a carotid body tumor? How will you differentiate a malignant lymph node, and how will you differentiate a tuberculous lymph node? By your clinical examination.
Ma'am, paraganglioma and the carotid body tumor can be ruled out with a history of significant history, long-standing history of neck swelling.
I think Madam's question was very clear as to how do you rule out tuberculosis and how do you differentiate, not rule out? What are the clinical palpatory findings that are very typical to
So Latika, like if you describe a malignant node, it will be hard, it will be, I think, restricted mobility, skin puckering may be there. So that kind of thing is what everybody is asking you.
So that's what, Latika, first I asked you, what are the points in favor of a malignant lymph node that is increasing in size? Size, shape, consistency, fixity to the surrounding structures, all these are features suggestive of a malignant lymph node. Increased size and spherical in shape, firm to hard in consistency, fixity to the surrounding structures. Tuberculous lymph nodes will be usually matted. It won't be like a firm to hard consistency lymph node. Carotid body tumor, there are other specific features like the mobility and the splaying of the carotid bifurcation and all. These are the features which will help you to identify a malignant lymph node. So then you will go on to your radiological and other investigation to confirm your finding.
Yes, ma'am.
Yeah. Now, how will you proceed with this lymph node?
After examination, I will order few investigations to the patient. That is USG guided core biopsy with P16 and EBV, IHC, and PET CECT. We will further do the FOL examination with the NBI and EO examination under anesthesia and rectal examination.
So the first will be core biopsy. You don't want to go for a fine needle aspiration cytology?
Ma'am, it can be done. As per guidelines, fine needle biopsies should be a first investigation to be done with the suspicious node. But if the node is cystic, then there may be a low yield in the FNAC. In that case, if we require ISC also, we need our tissue. So USG guided core biopsy is much better in that case.
So practically, how will you proceed with this lymph node? Do you do a core biopsy first or as an FNAC first? This is not a cystic node. This is a firm node, you said.
Yes, ma'am.
So in your outpatient practice, how will you proceed with this lymph node?
Ma'am, USD code, guided core biopsy.
So you will do
Latika,
a FOL after USG guided core biopsy, or
No, sir, in the OPD only, we'll do the FOL with the NBI.
so again, Latika, now Latika, you're
so the examination on the anesthesia, FOL, TL scopy, nasopharyngoscopy, all has to be done on the upfront setting during the examination, and only after you have ruled out the primary lesions on examination, then only you should think about whether to go ahead with FNAC or USG guided core biopsy.
So I think, Latika, this has very practical implication. The way you put it is confusing all students because they're asking which should be done first. Should you do a FOL after a PET scan or before a PET scan? So this has an implication because you're presenting it to all of them. Everybody's watching your slides, isn't it? So you cannot just randomly put anything on your slide. So you'll have to say in your clinical practice what you do. Would you do something clinical that is there? You have to do that first, right? FOL. And why do you have to say FOL with NBI? Do it routinely? Is it absolutely necessary? Now you have to justify that because you said you're going to do FOB with NBI, right? So first it has to be a fiber optic laryngoscopy or a Hopkins, scopy as well, whatever you have at your disposal. And then you will go ahead with an ultrasound guided FNA for better yield and a core biopsy. If as per the ASCO guidelines, as we mentioned, a core biopsy now is considered necessary because you need to know whether it is P16 positive or Iberish positive to further manage the patient appropriately. And then you would do imaging, and then you would do an examination under anesthesia and a image guided biopsy of any suspicious site that is there on your imaging or on your copy, that is examination and anesthesia. Now, Latika, you said you will do FOL with NBI. Please justify.
Sir, I have done already Hopkins examination in which I have not found any primary. So I want to do the FOL with the NBI because in the superficial mucosal lesion, NBI proved to be easily found the superficial lesion. So I want to proceed with FOL plus NBI and followed by my imaging.
So what is the evidence for you to say that NBI is going to help you identify your primary better? And how do you identify a primary on your narrowband imaging? What is the principle in which your narrowband imaging works?
Sir, narrowband imaging works on the blue and the green light. Blue light at 415 nanometer and green light at 540 nanometer, which is shown to the mucosa, and brownish, reddish to brownish. If the lesion is suspicious, then it will absorb the light, and reddish brownish area we can get on the NBI imaging.
What are the how do you what are the patterns of vascular loops formed that are being described, and which has least suspicion and which has most suspicion? You're not saying anything of that sort. You're doing NBI, but you don't know how you will interpret your NBI.
Sir, yes, we have to see the intra capillary routes.
Yeah. So how many types are there, and which is the most suspicious category? So you will biopsy anything that is seen on NBI, or how would you biopsy? What is the suspicious thing that you're finding on your NBI?
Sir, if it is showing the type 3.
What is type 3?
Sir, there is a abrous pattern of the vessels. And
so what is it? What pattern? Sorry. What pattern?
Sir, abortion patterns, diameter of the vessels.
No. See, Latika, basically, you're getting into a trap, which you'll never come out from. Right? So you
Yes, sir.
don't have to say unnecessary things here. You just F1 is good enough. There's no evidence to say your NBI improves your yield in any way whatsoever, right? So you're saying
Okay.
unnecessary things. You might be doing it in your practice, whatever that is. But when you're saying it, this is an rehearsal for your exams. So in your exams, you have to say what is practically done, what is the evidence that is available, and if you say something, you should be in a position to justify. You cannot just say anything that comes to your mind. And there is another question that whether the in the chat box, whether PET CECT is always essential, which it isn't. As was mentioned, a CECT is good enough. And if you don't find anything in your clinical examination and CECT is when your PET scan is actually advised as per the ASCO guidelines. But you can consider that as a first investigation depending on the availability, affordability of the patient and various other aspects, right? So
Yes, sir.
Latika,
over to the
first,
other.
for the basic things should be mentioned first. What are the advantages of doing a flexible laryngoscopy after your Hopkins? So why do you want to do a flexible laryngoscopy? So it should be a triple endoscopy. You want to rule out all primaries in all the other areas in your upper digestive tract, right?
Yes.
So yeah, that has to be done as Dr. Shiva was telling. It should be in that order only. After your office Hopkins endoscopy, you should move on to your pan endoscopy. So in a flexible scopy, the advantages over a Hopkins, what are all the hidden areas will be visualized under magnification, right?
Yes,
And
sir.
even with or without NPI, if you have NPI, that's good. So according to NPI also, you can direct your NPI directed biopsy, which can the detection of primary will be more. So in that way, you have to proceed. And then comes your radiological evaluation. So as it was told earlier, CECT was the first line of imaging according to the guidelines. But if the patient can afford and if it is freely available, PET-CT is well and good. So what is the sensitivity and specificity over PET-CT over this CECT?
Ma'am, PET has if compared to the CECT, so it has a better specificity around 70%, and it has a good sensitivity also around 86%, and detection of the primary accuracy rate is around 40%, ma'am.
So in how many what percentage of the patient the PET helps or overtakes the advantage over and above that of CT scan in changing the management or detecting the primary?
Sir, there are few studies which says that in the 20% patient PET shown the mets and primary, another primary also, and make the we have to change the plan accordingly in 20% of the patients. There is a study by the Rusthoven et al. In 2004.
Any meta-analysis that has been conducted recently, because there have been many studies on impact of PET-CT on change in management pattern based on the findings in the PET-CT over and above CT scan, conventional imaging, that is CT scan.
Sir, there is a meta-analysis by Ibrahim et al. And V et al. But that study was done in 2009. Meta-analysis.
Yeah. So
And
roughly
there was
around
a
20 to 30% of the patients.
Yeah.
So the question in the chat box is whether panendoscopy or imaging. So for all practical purpose, the imaging first will guide you to locate your lesion in your panendoscopy. So better to go for a scan and then go for a biopsy, endoscopy. So Latika, what is the advantage of some people advise MRI as the first line of treatment? Is there any advantage over CECT for MRI?
yes,
It's not in the
ma'am.
guideline. I was just asking. PET MRI, MRI, some people will advise for specific purpose over CECT.
Ma'am, yes, for the soft tissue, we can advise MRI, but for the meds, PET is more better. And there is a hybrid study also in the literature by Varina et al. In 2016, which has compared PET MRI and PET CT scan. And they have found that PET MRI is more sensitive for the cervical adenopathy, and PET CT is more sensitive for the chest met, pulmonary mets.
Yeah. So actually, if you don't have a availability of PET scan, MRI is preferable for some small lesions in the base tongue, in the oropharyngeal area. So some of the lesions in the base tongue and all will be picked up by MRI rather than a CECT. That's what I wanted to ask you. And PET scans have some sort of like false positivity rate also. So the combined PET CT or a PET MRI will have more of anatomical localization. So PET will have some sort of a what you can pick up by PET scan. This is the metabolic activity, right?
Yes.
So the CCT or MRI will have more of anatomical localization. That's what the advantage over PET. But PET have more of a false positivity rate also.
Dr. Latika, yeah. ma'am.
So Latika, what is the role of doing blind biopsies today?
Ma'am, as per guidelines, there is no role of blind biopsies today, and this is shown by a study also by Tansler et al. In 2016, in which they have shown that these biopsy didn't end up any plan change, or they are unable to found any primary.
What is the role of tonsillectomy?
Ma'am, as per literature, if the patient is HPV positive, because most of the studies is done in the HPV positive with the TORS and the TLM. So in that patients, they were able to find primaries around 70 to 80% of the patient after tonsillectomies. But the studies which was done in the HPV negative patients, only 13% of patients they have able to found the primaries.
Okay.
13% or even lesser. In fact, 2 studies show 0%.
And you're correct,
And
you know, when you answered, you also answered in context of the population studied. Okay. So that's very important for everybody to answer, because you have to talk about the 75 to 100% that is seen in the Western population is essentially because of the HPV positivity. In the HPV negative populations, the role is absolutely questionable because of the lower incidence of finding primaries.
So I think generally we can say that PET scan have a detection rate for primary as 25%, 25 to 30%, and tonsillectomy has a proven detection rate of around 25 to 30% again. But maybe in the Western countries, it will be more. So in our continent, it will be like 25 to 30% rate. What are the molecular assays you want to do in your core biopsy? You said about guided core biopsies.
Ma'am, I want to do the P16 and Iype.
Yeah, Epstein-Barr virus by your in situ hybridization and HPV by your PCR technique.
Yes.
Yeah. So don't say P16, because why will you not say P16? IHC?
Ma'am, because it can be positive in other primaries also, like in the lung and the skin, depending upon the prevalence, low prevalence and high prevalence area.
No, I'm looking for some other answer. If you do P16 IHC, do you have any evidence to talk about the concordance and discordance between P16 IHC and the in situ hybridization or the PCR?
No, ma'am.
You have to read the EPIC study.
Okay.
EPIC study.
Yes, ma'am.
where they talk about the discordance between the P16 IHC and the HPV as either being tested with PCR or in situ hybridization, which talks about dividing these patients into 4 groups, actually, the P16 positive, what we were calling as the HPV related cancers. So you have the P16 that is positive and the HPV that is positive. That's the best group. But then you have a P16 positive, HPV negative. You have a HPV positive, P16 negative. That's the intermediate risk group. And then you have both that is negative. And the connotation of all these 4 groups and the outcomes is different. So you need to read the EPIC study, lead author Hisham Mehana.
In fact,
Okay,
we
ma'am.
discussed this article in our journal club. I'm not
We
sure
did,
if...
no? Yeah, yeah. So
Yeah, we
then-
did. We did discuss this.
So when you get a biopsy report of P16, so what are you looking for? How they report it, which will be indicative that this is, the patient is HPV positive.
Hello.
Yeah.
See, if you're not speaking, then please mute yourself.
Dr. Latika,
Yes,
in
sir.
your biopsy sample,
Yes.
suppose you have done the biopsy and you have sent for P16 reporting, and what is the report that you are looking for to determine whether it is HPV positive or HPV negative?
Sir, the report will mention just the positivity of both, whether EBV or P16 positive or negative. They mentioned only the positivity or negative report only.
So the staining has to be whether it has to be nucleocytoplasmic staining. What is the percentage, and is there any term called diffuse block positivity or simple positivity is considered to be positive? So there is a difference between the positivity for HPV and that for EBV that is in the Iberis test.
Okay, sir. I will read, sir. I know.
Yeah,
Yeah. So
another
diffuse block
limitation for
positivity is
elevated
what we are looking
P16.
for.
Yeah,
But in
another
case of
limitation for
Iberis,
elevated P16 is some of the cutaneous squamous cell carcinoma also will have some sort of elevated P16.
Yes.
Okay, proceed.
so diffuse block positivity is what we are looking for. So it has to be absolute, almost 70 to 80% nucleocytoplasmic positivity. Then only it is considered to be positive in case of HPV. However, in Iberis, any positivity is considered to be positive. So and even in EBV, we have got 2 kind of investigation. Among them, EBV is much more, Iberis, that is in situ hybridization, is much more sensitive.
Okay, sir.
So Latika, what are your, can you enumerate some of the theories behind this unknown primary? Why you are not able to find out this primary in spite of huge N2, N3 lymph nodes? Any theories behind it?
Ma'am, it has been said that the primary may be also in small and indolent, that it will move by the medium, and another is the primary is so small that with recent available imaging, these imaging will not able to pick up the these primaries. And another old theory which is obsolete now is the squamous cell proliferation in the lymph nodes during development, that is bronchogenic brachial cyst carcinoma, so which is obsolete now, which is not used now.
Okay.
So Latika, now next what? So you have proven that this is a squamous cell carcinoma, HPV negative in a lymph node, and all your investigations have not, your examination, your mucosal examination, your PET CT has shown that there is no primary elsewhere, and there is only this level 2 lymph node. PET CT has not revealed any additional lymph nodes. So you have an unknown primary with a metastatic neck node at right level 2. What is your further management plan?
Yes, ma'am. Ma'am,
You want
this
to do anything
node
else?
will.
Sorry, you want to do anything else, or this is enough?
Ma'am, this is enough to plan further.
Okay. So tell us, what will you do next? What is your line of management? What do you propose for this patient? 52-year-old lady, no other significant comorbidities, 4 into 4 centimeter node.
So, ma'am, in this case, both surgery or non-surgical option
This patient has
can
come
be
to you,
given.
madam. This patient has come to you, madam. What is the right treatment for me? And you justify that approach.
MRND, modified radical neck dissection, 1 to 5.
Is that how you talk about a neck dissection today? Sorry. Shiva, Elizabeth, you can ask. So what is the neck?
Yeah, Latika, is it a metastatic squamous cell carcinoma?
Yes, ma'am.
What is your histological finding here?
Ma'am, it's a metastatic, they have reported metastatic squamous cell carcinoma, P16 and EBV negative.
Okay. So according to you, it is N2 node. Or? Okay. So you, you want to go for a surgery, primary surgery?
Sorry, ma'am.
What do you want to do for this patient? Primary surgery?
Hello. Ma'am, since it is an N2A node, I want to, if there is no primary in the, I am unable to find any primary with the imaging or examination. So I want to give offer the surgery in the form of MRND 1 to 5 to this patient.
Why? What is the advantage of surgery over any other modality of treatment?
Yes, ma'am. It will give me a better staging. In the post of HPR, it can upstage the disease, which may change my treatment for treatment modalities, and better radiation portal delineation, and
you have any
this
data
much only.
to say that surgery is better than radiotherapy?
Ma'am, till now, there is no data which shows that surgery is better than radiation. But in the few retrospective studies, retrospective studies by Liu et al., in which they have taken around 500 patients, they've shown that in these type N2A nodes, surgery plus RT, 5 years overall survival is better than the radiation alone, with the hazard ratio.
Yeah, we didn't hear the end of it.
Ma'am, a study by meta-analysis by Liu et al. In 2016.
Yeah. So what was the hazard ratio you said? Point?
Ma'am, here overall, relative risk 0.6.
So you did surgery on this patient, and then what is your histopathology report?
Ma'am, in my another not suspicious not.
Latika, I can't hear you. Yeah, your voice is breaking.
I mean, in my case, there is a on the PET scan, there is one B port nodes are also suspicious.
Level 4 nodes, huh? What did you say?
No, ma'am. Ma'am, level 1B node.
Okay.
So this
Okay,
case will be a N2B. So I want to offer chemoradiation in this case.
Why have you changed from surgery to chemoradiation? Isn't
Ma'am, actually,
accurate? Yeah.
previously, ma'am, only there is one node on the examination, but on PET-CT there is two suspicious nodes. So in view of that, I want to give a CERT to my patient.
What is your expected outcomes?
Ma'am, if it is an N2 node, then there is a overall survival of less than 50 to around 50 to 60%, and for N2B node, it will be around 35 to 42%.
Because this is HPV negative.
Yeah, we very HPV positive.
So you're saying you're going to give CTRT. So are there any radiation oncologists or who would talk about the volumes of radiotherapy? Sambit, you'll tell them about the volumes of radiotherapy?
When we
If you agree.
talk about ma'am, if in PET scan we have got two nodes, then it will be more preferable to go ahead with definitive CTRT. Given the fact that we have got the node in level 1B, the chances are that the primary may be from the oral cavity or oropharyngeal region, more likely to be more from oral cavity. So definitely during the treatment, our volumes has to incorporate the high risk volume. Will be incorporating the node during the planning purpose. However, given the fact that we have got a node in 1B and 2, we could take the mucosa. We may or may not take the mucosa of the larynx, and that has been debated over a period of time. And since it is HPV EBV negative, the nasopharynx may be taken in the low risk volume, not necessarily to be taken in the high risk volume.
What about the other nodes in the ipsilateral neck?
Yeah.
Ma'am,
The contralateral neck and the rest of the neck nodes which are not involved are to be taken up in the low risk volume, and we typically give around 50 to 54 gray, depending upon the fractionation schedule. The primary node with the margin are to be given 66 to 70 gray, whether we are treating with IMRT SIV technique, that is at 2 gray or 2.2 gray, preferably at the other volumes 50 to 54 gray, that is the prophylactic dose.
Latika, you were saying something. Did you get what Dr. Nanda said?
yes, sir. Yes, ma'am.
After that, what will you do? Are there any other questions for the management? What will be your plan after CTRT?
After CTRT, patient after once got completed. So I want to call my patient on the follow-up. So I want to get PET-CT at the 3 months.
Okay.
If I
So Latika, this is very important. Like Dr. Sarbani and Dr. Nanda was saying about the dose of the radiation to the neck and also to the mucosal field, and also the area covered. That is very important. And also the post CTRT follow-up. You were saying about PET-CT after 3 months. You don't want to do a clinical examination because it was level 1B node. You always have to look for anything in any evidence of primary in the oral cavity. right? It's in the level 1B area. So after CTRT, you definitely have to go for a clinical examination, thorough clinical examination on every visit, and you can go for a PET CT definitely if you want to have some follow-up evidence of any residual node and all. You can go for a PET CT after 3 months, but thorough clinical examination is really important in all these patients.
Okay.
Why not surgery in this case, sir? And when would you do surgery in such patients? So 1 minute, let's just finish this case, then we'll come back to why not surgery and why surgery. So then you've said CTRT, and as Dr. Elizabeth has correctly pointed out, you will then do your clinical examination of the face, neck, essentially to rule out the emergence of subsequent mucosal lesions, mucosal primaries, and then go ahead with a PET CCT. So in the PET CCT, there are three situations. One is you have complete metabolic response CMR. Then what do you do?
If there is a complete response, I want to follow up my patient on the 3-month visits. Clinically, I am found. Sorry, ma'am.
For every 3 monthly for?
For every 3 monthly for 2 years, and for after that 6 monthly till 5 years, and then 1 yearly.
And what will you do at every follow-up?
And with the Hopkins or FOL.
You do a mucosal examination, a thorough mucosal examination of the neck, right? Clinical examination of the neck. When will you repeat imaging?
Ma'am, if I found something suspicious clinically, so in that case, I will repeat. I want to repeat this imaging only. In that case only.
Okay. Do you know about the NIRADs?
Yes, ma'am. But not able to remember.
Okay. So then you're going to then I suggest everybody read NIRADs as to when you should be repeating your imaging, what imaging and at what frequency. After that, okay, so now this patient, the second situation is when you still have an uptake in your lymph nodes. What will you do next? There is partial response, but not CMR.
Ma'am, then I want to plan my patient for a salvage neck dissection.
Seedha.
Ma'am, depend if it is a HPV positive patient. In that case, I can observe the patient, because sometimes in the cystic node that will regress over the time. But if it's a HPV negative patient, then if there is a equivocal response or uptake on the PET, then I want to go ahead with the surgery.
Would you like to establish any diagnose any histopathology prior to going ahead with the
Yes, ma'am. I want to get guided FNAC prior to go ahead with the surgery.
And if your guided FNAC is negative? What do you do in practice? So this is where the NIRADs will come in also. Okay.
Yes.
Are there questions on the Elizabeth or Sambit or Shiva? Any other questions?
What is the rate of nodal positivity in a salvage neck dissection in such cases?
Ma'am, I don't remember exactly, but around 30 to 40%.
Yeah, most of the time your pathology might come as negative also. So you have the final pathology. So you have to counsel the patient regarding this. So if there is a radiological evidence of residual node, if you don't get a histological evidence, you have to, whether you want to go for a comprehensive neck dissection in such salvage setting, or you want to go for a nidosectomy or super selective, because it's already covered with your CTRT, whether you want to go for a comprehensive neck dissection?
So what are the factors that you're going to consider before deciding your extent of neck dissection?
Ma'am, I like to go modified radical in the salvage setting also, depending upon if the node is showing any extranodal extension.
So Latika, you have this patient, a 52-year-old female lady with a 4 into 4 centimeter node with a partial response after complete CTRT. There are no new lymph nodes in this patient, but there is a residual lymph node which is equivocal or has shown partial response on your post-treatment response scan. So what will you do in this patient?
Ma'am, to go ahead with the salvage surgery.
No, so what is the extent of surgery is what Dr. Elizabeth is asking you. Will you just do a nidectomy? Will you do a comprehensive neck dissection? What will you do? What will be your extent of neck dissection?
Ma'am, it would be 1 to 5. There is no role.
This patient already had a CTRT and your primary disease was in level 2 and your 3, 4, 5 levels are empty. Then why you want to give the morbidity to the patient by doing a radical neck dissection in this patient? You can avoid the other levels. And you are always justified in doing only the involved levels because it is already radiated neck. So maybe if you are in doubt, you can go, you have the frozen section facility. You are justified in doing a level 3 node for frozen and then proceed. Otherwise, you are not. You don't want to create morbidity because it is already an irradiated neck. Why you want to take out all these structures like sternomastoid and by doing a radical neck dissection, the complications will be more. So you can select your levels and especially after your radical treatment by chemotherapy and radiation.
Asim, how much time do we have?
I think the time is over. It's still
over now.
We have another 5 minutes.
Okay. Then we can quickly take up those questions on the chat box, I think.
Yes, ma'am.
Yeah. So one of the questions, I think 2 of them asked the same question. Why not do surgery? Why CTRT? And what is the role of sentinel lymph node biopsy? Is that what you asked, Rajyoti? So why not surgery upfront rather than CTRT?
Good evening, ma'am.
Good evening.
I asked about the super selective neck dissection.
Super selective, okay.
Yeah.
So tell us, Latika, why not what you call surgery upfront?
Because since it is an N2B node, there may chances of we getting any extranodal extension in the post of HPR, which gives the trimodality treatment to the patient. Because due to this trimodality treatment, that will give the morbidity to the patient. So in any case, we have to avoid that trimodality treatment. So we want better to give the CTRT.
Is that acceptable? So, there are actually 2 schools of thought on this. And today, as you know, if you look at literature, you will find both sides of the thing. You will find data to support either approach. The only advantage of doing a surgery upfront in this patient would be possibly to get more of the histopathology extent rather than anything else, because as Latika has said correctly, this patient will end up getting multimodality treatment, which may or may not be which may only increase the morbidity in this particular patient. So you could do surgery, and the reason for doing surgery will essentially be to get adequate information on the pathology of and the extent of lymph node involvement, which is not otherwise seen on the PET CT. So that will be the advantage of doing a CT, a surgery in this particular patient. But yes, We would usually in such a patient in the era of PET-CT perhaps work the other way, do CTRT and then reserve surgery for salvage. But of course, we don't have a clear-cut answer in literature, and that's why I guess Shiva's child is going to try and answer this question. Elizabeth or Shiva, would you like to answer?
As Sarbani was saying, actually, this is the correct, as Latika has pointed it out correctly. We want to avoid a multimodality treatment for this patient. So if this responds to a CTRT, then you can very well follow up such patients and you can avoid a morbidity of a surgery followed by a CTRT. So in our institute also, we are practicing this.
I have a question from Sarbani, ma'am. Madam, will there be any reduction or in the dose of the radiation in the adjuvant setting if we are giving radiotherapy after surgery?
If we give radiotherapy after surgery, as Sambit mentioned, we are then treating treating actually microscopic disease. And if you're treating microscopic disease, instead of giving 70 gray, you will usually give a 60 gray 30 fractions equivalent. So that way about 10 gray lower. And then in some cases, you may choose not to treat the entire neck, but treat less of the neck just because, see, these things now are very controversial in the management of unknown primary. How much of the neck to treat, how much of the mucosa to treat. But definitely, if you've done surgery and then given us the patient for treatment of the for adjuvant treatment, the doses will not be as high as 70 gray if you've had an R0 resection. It will be 60 gray 30 fractions. And depending on the absence or presence of extranodal extension, we would then give adjuvant CTRT. The other thing you have to remember is that this justification for giving adjuvant CTRT or doing CTRT in unknown primary with metastatic neck nodes is essentially an extrapolation of data from squamous carcinomas with a known primary. So you have to remember this because there is no data that talks only about any kind of level 1 evidence that talks only about SCUP. So that is what you have to remember.
Okay, ma'am.
Elizabeth, the last question about that supraselective neck dissection.
Yes. Yeah, it's actually a post-CTRT neck node. So most of the cases, as you said, NIRATS has to be taken into consideration. And if you have a cystic node there with the necrotic features inside, most of the time the final pathology might come as negatively. So very well, if you have a frozen section facility, you can proceed with according to that frozen. You can proceed to take out the lower level neck nodes. Otherwise, always an nidosectomy is advisable and justifiable to avoid morbidity to such patients.
I think there is one more question as to Shatadru is asking, how do you develop, call this a small volume neck disease or a large volume neck disease? That is essentially by going by the end status and the size of the lymph nodes and whether you're expecting extranodal extension or not in that particular lymph node. There is one more question. There's one more question.
Tongue-based mucosectomy.
So, Latika, based on the ASCO guidelines, would you do a tongue-based mucosectomy in a patient like this? If yes, why? If no, why?
Ma'am, as per ASCO guidelines, they said tonsillectomies followed by the tongue-based mucosectomy. They were able to find the primaries in 60% of the cases, but in our practice, we are not doing any tongue-based mucosectomies and tonsillectomies because there is no proven role of in the literature for these patients.
And why is that? And why is that? What did when tongue-based mucosectomies, what was the yield of the primary in what proportion of patients?
30% cases, ma'am.
And what was the association with HPV infection?
Ma'am, mostly these cases were done under the TLM and the tolls, and mostly these patients in these series taken were the HPV positive patients.
So that is the justification for why you will not do a mucosectomy in our population, especially if it is HPV negative. Correct?
So in this particular case, is it really indicated to go for
No.
a base tongue mucosectomy? She said that there are 1B lymph nodes positive. I really doubt whether it is positive, because in bad oral hygiene and in our population, around 60 to 70% my patients might come with a enlarged lymph nodes in 1B, may not be significant. So I don't think in this case it's really indicated for a base tongue mucosectomy if 1B nodes are really significant. Or
Yeah.
it could be something like an inflammatory node. So I don't know whether it is really justified here.
So Latika, how will you counter what Dr. Elizabeth has told you, or how will you perhaps accept what I would accept it as what Dr. Elizabeth has told you? Do you accept it, or do you want to counter what she's saying?
Ma'am, yes, it can be from the it can be an inflammatory node, but
No,
according
forget
to
the
size,
inflammatory. Forget the inflammatory. I'm talking about the part where she says that supposing this is truly a 1B positive lymph node, then
yes,
would
ma'am.
you do a base tongue mucosectomy?
No, ma'am.
She said
No, ma'am.
no. Why?
Ma'am, in that case, I will try to found my primary in the oral cavity per se.
Okay. Okay. Fine. Take it. Okay. Anything else? Anybody wants to say anything else?
I think, ma'am, we'll finish it now.
Okay.
Yeah.
Fine.
So thank you, everyone. Thank you for joining. And I thank Dr. Shivakumar, Dr. Sarbani, Ghosh, Laskar, Dr. Elizabeth Matthew, and Dr. Sambit for joining, and Latika for the presentation. And thank you all. We'll be meeting once again on 25th of January. And we'll be having a discussion on role of neoadjuvant chemotherapy for organ preservation in oral cancer. So thank you all for joining.
Can you send us the link also? Can you please send us the link too?
Sure, ma'am. Sure.
Yeah. Thank you.
Thank you, ma'am. Thank you.
Thank you,
Bye.
Azim. Thank
Thank you,
you.
ma'am.
Thank you all.
Bye.
Bye-bye.
Good night.
Thank you for talking.
Thank you, Sambit.
Bye, Sambit. Yeah.